Well, welcome to the second of our series. I'm David Peters. I'm Professor of Integrated Healthcare here. For those of you who weren't here last week, I may have to tell you a few boring things again. This is the Faculty of Science and Technology that I'm welcoming you to, and it's a very broad faculty. I said last week we stretch all the way from acupuncture nearly to zoology, but we certainly have a very distinctive palette of courses and of research, from complementary medicine all the way to cell biology and molecular biology. We're inaugurating the Centre for Resilience, which is a new research and practice project. We are training people in resilience, including people in the NHS, and we are researching resilience, and we're finding ways of assessing the physiology of resilience. So we've got several really interesting projects there. But resilience is such an enormous topic now, especially wherever there's a frontline situation. And I know we're all here because we're concerned about it in our various ways. I just wonder, just a small show of hands for anybody who works in or near the NHS. That's probably 60% of people. Okay. Well, I was thinking about this, and it proliferated into a kind of series of C's. Concern is the first one, and obviously compassion is the second. But we're in a crisis. I think that's not too much of an exaggeration. And last week Jill Maben talked about it in terms of what's happening in nursing, seen through the eyes of her research. Once again, were many people here last time? Yeah, again, a fair number. Thanks. That's good. Chris Irons talked about the neurobiology of compassion and how we're wired for it, but only in the right circumstances. And it seems a lot of the time now the circumstances aren't as good as we would like to see them, because there's a crisis of cost, there's a crisis of care, there's a crisis around cure, particularly with chronic disease, and increasingly, when you look at the burnout figures, there's a crisis of commitment. I suspect behind it there are two more C's, and that's a crisis in culture and a crisis of concept. The concept that we're working with, biomedicine, it's not working. Anyway, those are my particular hobby horses, but I want to hand you over tonight to our chair for the series, Dame Professor Donna Kinnair, who will keep you all in order.
On an ongoing theme, I still want to push the point that we do work in a service where we're giving a lot of care to people, and most of us try to give that care in a compassionate manner. And I did say last week that I had taken over a service. I'm describing A&E in one of the biggest A&Es actually in London, in Barking, Redbridge and Havering Trust. And I did go into the trust, and my first day I did wonder what had happened to compassion. I don't know if I said this last week, but the first thing I saw on my first morning was a nurse pushing a patient that was half-dressed along a corridor. So this poor woman was slumped in a chair, she had nothing on, and what was really interesting to me is that I knew that nurse didn't even see that patient. And when you get to that in a hospital, that we are giving care in, you know there is something wrong. Now, talk about professional standards, I sort of go to professional standard mode automatically, because I don't know for some of you, but if any of you were nurses, that's the way we were trained. Everything was about professional standards and making sure that we stopped there. So I stopped this nurse in the corridor and I said to her, if that was your mother, would you appreciate her being pushed along the corridor like that? And the look that she gave me meant that she hadn't even registered that this lady was half naked, half slumped, and being wheeled along, no blanket, nothing. She just didn't register that this was not acceptable. So it obviously had been going on for some time, and it was now believed. So when I that was your mother, and I was pushing her down the corridor like that, would you appreciate it? And she stopped and she thought, I think it was the first time she thought about it, and I have to say to you, she said to me, no, in this kind of off-handed manner. And I said, well, maybe we could have a longer discussion about it afterwards, because, but it would be nice just to get her dressed and sit her up in a nice manner. So she did do that, and we did go on to have longer discussions. We started to have what I call keeping in touch with nursing and compassion days, where we started to have the conversations about professional standard. So I'm giving you an insight into my everyday world, but it is interesting that it's not just my hospital that you can walk into. There are many hospitals and many places that you can walk into, and the care and the compassion just isn't there. And it is something to do with the way in which we treat people. So my model of care is, how do I treat my staff so that they can go on to treat their patients in the same kind of manner, with compassion. So today, as our new speakers talk about setting those professional standards, what I would like to know, and I'm really interested to learn this, is can we really regulate for this kind of stuff? I think what I did that day, that first morning, set the tone of what I expected in my department. And therefore, people know that I regularly regulate as I walk along. But is there a professional way of something like CQC or others, regulators for compassion? So I'm really looking forward to the conversations that we're going to have this evening. I've now volunteered to, you'll see me again next week, unfortunately. My husband's not too happy. But I'm really looking forward to these discussions because I think they are so important. So I'd like to hand it over.
Good evening, everybody. It's a pleasure to be here. Be here again. I was here last week. What I'd like to talk about tonight is whether empathy or intelligent kindness can be designed into healthcare. And I've written my talk for tonight with last week's lectures in mind, and David's kind of touched on what Jill and Chris Irons were talking about last week. What I'm going to say to you tonight is a work in progress. I haven't tried this out with any audiences before, and I'll be very interested in and grateful to hear your reactions and comments. What I'm going to do is begin by talking about why I prefer the terms empathy or intelligent kindness to compassion, and then touch on two starting points that I think are very helpful in thinking about all of this. And then I want to spend most of the time reflecting on the medical model and on medical professionalism and the part that they play in shaping the culture of health services. And then I want to end with some reflections really about what the medical profession might do to foster empathy in services. The term empathy is synonymous with compassion, but it is different. And if you look at the dictionary, the synonyms for empathy include affinity, appreciation, recognition, and being on the same wavelength. Whereas the synonyms for compassion include mercy, clemency, grace, and charity. Words that are more religious than secular in origin. And my preference is for empathy or intelligent kindness, partly because I think that discussions about patients' experiences of care and about cruel and unkind acts have been framed in this country by the media and by policymakers and by practitioners as all about nursing, all about care assistance, and all about inpatient care. And I think it's very important to find language that brings in other professions, that brings in support staff, and that brings in other settings. So I'm as concerned with the ordinary transactions between patients and GP receptionists or patients and outpatient clerks as I am with what happens between patients and health professionals. And in my view, actually, the best language to use is the language in use, that's to say plain English, and to talk about common and ordinary words like kindness, like warmth, like welcome, like friendly, because those are the words that I think everybody right across the system at every level understands. But my starting point really for thinking about what I want to talk about tonight is this, which is the well-known aphorism of Paul Batalden, one of the gurus of quality improvement in healthcare, who said every system is perfectly designed to produce the results that it gets. And I think it's very important to understand that when Batalden's talking about the design of a system, he's not thinking about intentional design. He's also including the features of systems that have evolved organically and the features of systems that are there today but are actually hangovers from the past. My other starting point is this, which is the world of design and design sciences. My charity, the Point of Care Foundation, is very interested in co-design of services with patients. Designers working on products and services, because designers work on both, focus on three features. They focus on the performance. Does this thing do what it's meant to do? They focus on the engineering. Does it do what it is meant to do, excuse me, reliably, safely? Does it do it in the same way every time? What's the error rate in this product? What's the error rate in this process or service? And they also focus on the aesthetic. What does it look like? What does it feel like? What does it smell like? What does it touch like? What does the end user, the customer, feel about this experience of this product or this service? So if you put the two things together, I'd argue that the performance, the engineering and the aesthetic of health services is a product of the whole system. And empathy is a feature that here I would describe as part of the aesthetic of the service. So if we want to design empathy into a service, then I think we need to understand the parts of the system that are involved and how we might influence them. And here are some features of health systems that significantly shape the way that staff interact with patients. So last week, Jill Mabon and Christopher Irons were talking very much about the bullet points that are there in red. They were talking about high demand, high levels of acuity and patient need. They were talking about fatigue and stress and burnout. They were talking a bit about pseudo teams and real teams and about the quality of leadership. I've added some more that I think are critically important for patients and for their experience of care. The steep hierarchies and professional divisions that divide the people who look after the same patient, the wars between specialists and generalists, the fragmentation of services, the fact that so many of our services use paper-based records, which means that the person looking after you doesn't necessarily have any information about you at all, because it's held somewhere else in a different part of the system. The very variable quality of the physical environments in which patients are looked after, and the fact that in some services, but not all, staff are working to achieve targets, and that impacts on the services that have targets and the services that don't. Now, I'm sure you would think of more features that you would want to add, but these to me seem to be some of the very important ones. But they're not enough. So I don't think that focusing on the ones that we talked about last week is enough on its own. So I don't think that, whilst these factors in red are incredibly important, and the beauty of them, I think, is that we now are beginning to understand what might need to be done to mitigate them or to reduce them. But in my view, this isn't enough to guarantee empathy for patients. And so I'd argue that the absence of stress does not guarantee that patients are going to be looked after with empathy. And the reason for this, I believe, is that some aspects of the health service, the way that services work, reflects the values and the priorities of the two dominant groups, which is doctors and managers. And of the two, I would argue that culturally, medicine is the most powerful. Of course, all the health professions have their own cultures, their own values and priorities, and support staff have their own. And there's not time tonight to deal with the complexity of the subcultures within the healthcare system and the way that they interact with one another. And I'm very aware that my talk this evening is in very broad strokes, and I apologise in advance because I am having necessarily to oversimplify. But what I want to talk about is the medical model and about professional standards. Because I believe that the power of the medical model and the way that doctors view their own professionalism shapes the culture of the system as a whole. And I believe that it puts empathy for patients at risk. I think it's the cause. I don't know if you're familiar with the work of Havering, the philosopher, who's written a brilliant book called Illness. And Havy talks about what she describes as the low-grade insults to patients that are part and parcel of using the NHS. And by low-grade insults, she's talking about chilly receptionists, she's talking about hopeless administrative systems, she's talking about the studied indifference of some professionals of the kind that Donna's talking about, the refusal to make eye contact with patients when they're in inpatient settings, and so on. And I believe that if we intentionally want to design empathy into services, we need to challenge the medical model and the current view of professionalism and think differently. The medical model is traditionally accepted as having these features. The doctor's the expert, and the patient complies with medical advice. Of course, today this is subject to a huge amount of challenge from patients themselves, some patients, particularly patients with chronic disease. Doctors are the dominant profession. Doctors are more powerful, they're better paid, and they have higher status than the other professions who they work with. The doctor's focus is on the disease, not the whole person. In fact, I think you could argue that the doctor's focus is increasingly on the cell rather than the disease or the whole person. And part of this paradigm is that the patient is not blamed for being ill, but the patient is also not responsible for their condition. I said this was the traditional model, and of course it's subject to challenge. And if we think back to the way that women have challenged obstetric care, for example, in the 70s and 80s, or the way that parents of children in hospital challenged hospitals right up until the 80s, it's unbelievable to me when I look back and see that it wasn't until the 80s that we took it for granted that parents would be allowed to stay with their children when they were in hospital. And of course there are many initiatives, particularly in primary care, which are trying to challenge this model, and there is the movement around person-centred care and the house of care. All of these things that represent challenges to the medical model, but I would argue that this is still the model that dominates the way that services operate. And reciprocally, patients trust doctors. Patients, that's the other side of the coin of the medical model and medical professionalism. And patients trust doctors for good reason. They trust doctors because doctors know things that they don't. Doctors can look inside your body. They know things about you before you know them yourself. When you're ill or you're injured and your normal life is disrupted, you know as a patient that the doctors who you consult, their insight, their skill, their expertise will determine whether you can or can't return to normal life and how rapidly you will do that. Patients are acutely aware of the power of doctors in all their transactions with them, from the most routine exchanges in GP surgeries where they're being referred for a blood test or a urine test, through to the dramatic theatre of A&E or the operating theatre or intensive care. And patients trust doctors partly because trust helps to mediate the discomfort that we all experience in social relationships that bring us into intimate contact with people who are more powerful than we are. Patients trust doctors because they're dependent upon them, and because they know that doctors have the power to make mistakes, they know that doctors have the power to ignore them, to make judgments about them, to disregard them, and to disappoint them. And I don't think patients necessarily think about why they trust doctors, but if they do, they probably rationalise the trust in the same ways that the medical profession itself does. That's to say, patients trust doctors because they think that doctors have a standard of professional values and ethics and standards of conduct that are in some way reliable. And although I think the general public and most patients would not naturally think of words like integrity and compassion and altruism, which are the words that you see in the writings of the medical profession about itself, I think that those words would chime with patients. I'm less sure that words like continuous improvement, excellence and working in partnership, which are now part of the discourse, are ones that patients would naturally kind of relate to. But I think the other kind of axis for patients' trust in doctors is their awareness of very long years of education and training and superior knowledge for that reason. What do doctors themselves think about their own power? Most doctors I know don't see themselves as especially powerful at all. In fact, most of them see themselves as victims, usually of management and sometimes of their own patients. They often talk about managers having the upper hand in the system these days, or government having the upper hand, or both. And doctors generally, I think, are acutely aware that they don't have the power today that perhaps doctors had in the past. I personally see the picture as much more complicated than this. And my view is shaped by the work of Elliot Friedson, who, like me, is a sociologist, and whose book on professional dominance, I think, is brilliant. Friedson focused not on doctors' own writings about professionalism and not on doctors' place in society, but on the question of who controls medical work and how is medical work performed. And he observes that doctors control medical work to a degree that most other craft groups, other professions, other working occupational groups don't have the same kind of control over the content of their own work. Doctors have a legal monopoly to practice. They have almost complete control over the technical content of research, of education and practice. They're often unhappy about the power of governments and managers, but they're really not subject to significant challenge in relation to either research or practice. They are, of course, subject to challenge about some of the conditions within which they work, some of the forms of payment and what they will be paid for, but that's not the same as a challenge over control over the content itself. And medicine is more colleague-dependent than client-dependent. That's to say that doctors are very motivated by the thoughts and opinions of their colleagues more so than they are by the thoughts and opinions of their patients. If we look at, there are of course doctors who view medical power as problematic and who write about that, but they're not the most powerful voices in the profession, I would argue. And if you look at the medical profession writing about professionalism, it largely ignores the question of power altogether. Good medical practice acknowledges the inequality in relationships between doctors and patients by default, in that it sees it as having the potential for abuse, but otherwise it doesn't see the everyday difference as something that's problematic. The Royal College of Physicians report on medical professionalism in 2005 acknowledged that doctors may have power, but then immediately sidestepped the issue and dismissed it rather airily, I feel, with a very simple assertion. It reads, "Control, authority, power and superiority are ideals that are not compatible with our view of the patient-doctor partnership as the fundamental unit of clinical practice." So that was it. That was the mention of it. And the word power doesn't appear in the BMA's report on medical professionalism at all. But I think that there's a great deal of evidence that doctors themselves collectively are aware of the unequal relationship that they have with patients and very uncomfortable with their own vulnerability. And I think that because doctors behave differently when they're ill from other people. Doctors, in the main, aren't registered with GPs. In the main, when they're sick, they self-medicate. In the main, when they're ill, they carry on working, or they present late with very serious conditions sometimes. They're especially ashamed of psychological and emotional difficulties and acutely alive to the stigma that's attached to not coping. And I would also argue that it's something to do with doctors' relationship to their own vulnerability that means that they don't see what's right in front of their eyes. So one of the things that's fascinated me over the last few years is the personal view column in the BMJ, which week after week after week, it seems, is written by a doctor who has become ill, writing about their experience of being a patient and saying, "I never knew it was like this. I didn't see what it was like being a patient. This is a very important thing," they say. "We must pay attention to it." And as a non-doctor myself, I think, how could they not see what's right in front of their eyes? So what are the implications of all of this for empathy or compassion, if you prefer that term? For me, the implication is that the effort to improve patients' experiences of care requires us to challenge medicine directly and much that's taken for granted in the medical model and as part of medical professionalism. And the reason for that, as I say, is that because I think that medicine is the culturally dominant force in our system. And because my experience of working with clinical teams on the ground tells me that again and again it's the attitudes of doctors towards this kind of work that essentially means that it will either sink or swim. So if doctors lend their support, if they lead work to improve patients' experience, it flies. If they stand back from it, it doesn't last. And if they diss it, it just collapses altogether. So, and for me, the sad thing is that I don't think that doctors yet, or the medical profession, really get this. I don't think they value the expertise or the skill or the knowledge that's required to change and improve services. If you look at who leads on patients' experience in NHS trusts, it's nurses and middle managers. There are very, very few doctors who are leading this work nationally. And if you look at what the GPs said in a survey that the King's Fund did 2 years ago, they rated patient feedback as a source of information 10th on a list of 10 possible sources of information to guide them in their practice. So my conclusions about what would make a difference. Within the profession, I'd like to see visible public leadership for everything to do with patients' experience of care. That would mean the Royal Colleges putting some resources into thinking about it. I'd like to see heads of medical schools, key figures in general practice and opinion formers in the profession writing and speaking about the importance of empathy for patients and showing that they think about patients' vulnerability and putting their weight into reshaping the environments. I'd like to see doctors trained to see that patients' experience, clinical quality and patient safety are all of a piece, and a piece that they themselves are responsible for. I'd like to see people within the profession publicly challenging the idea that doctors are different when they're sick, and I'd like to see them publicly saying that it's not okay to work when you're ill. I'd like to see them challenging the stigma and showing support for colleagues who aren't coping. And I'd like to hear doctors speaking up about the culture of fear within medicine, which it seems to me is whispered about by junior doctors who fear speaking publicly about the way that they're treated. And I'd like to see doctors publicly speaking about the damage that these very hierarchical ways of working causes to their colleagues and to their patients. And inside organisations, I would really like to see senior doctors who have influence on their peers putting their weight behind improvements in patients' experience and showing that they take patients' vulnerability seriously in their own organisations. And what that would mean would be that they would get themselves trained in the proven methods for seeing how the service works through the patient's eyes. That would mean that they themselves would be volunteering to do co-design. They themselves would be volunteering to be taught how to shadow patients, rather than saying that can be done by the most junior person on my team. I'm sure that you will have things to say about this, and perhaps thoughts of your own on other things that ought to be happening. We published a report from the Point of Care Foundation earlier this year called Staff Care, which is more about the kind of stuff that we were talking about last week. But thank you for giving me the opportunity to talk to you.
So, thank you very much for coming, and thank you for inviting me. And thank you, Jocelyn, for going first. I thought I better just tell you the smallest amount of what the Professional Standards Authority for Health and Social Care is, because we aim enormously successfully to be a very low-profile organisation. So hardly anybody's heard of us. We are a statutory body. We're UK-wide. We're accountable directly to the 4 parliaments of the UK, and we oversee health and social care regulation for professionals. So we oversee the General Medical Council, the Nursing and Midwifery Council, the Dental Council, Health and Care Professions Council, and so on. We have some pretty strong statutory powers, powers to investigate, powers to appeal cases to the High Court if we think the regulator has failed in its decisions to protect the public. Perhaps the most high-profile of those recently was the case of Janice Harry, the Director of Nursing at Mid-Staffs, who was suspended by the Nursing and Midwifery Council, and we appealed to the High Court and had her struck off the register. We were appalled of her argument that as Director of Nursing she wasn't responsible for the quality of nursing in the trust that she worked. Not something Donna thinks for a second. So we can do that, but we also have a role to advise the government on improvements to professional regulation, and we have a small but growing consultancy arm. So we're currently working in Australia. One of my colleagues is in Australia at the moment doing a cost-effectiveness review of the Australian professional regulatory system. We're doing some work in Ireland, and we've done some work in Canada. So, and another colleague and I are off to Hong Kong in September. So I wanted to, this evening, I wanted to muse on the words resilience, compassion and regulation. And the more I've thought about them since I was asked, the more confused I've become in my own thinking. And I'm not sure that I've got anything very useful to say to you. Certainly compared with Jocelyn's coherent argument. But let me share some thoughts with you, and I hope at least provoke some more discussion. So let me start with regulation. Everybody apparently knows what regulation is. You know, we certainly politicians have no doubt that they know what regulation is. But very few people can actually describe to you in a coherent way how regulation works and what it's actually supposed to be doing. If you look at CQC as a sort of major health regulator, although this has, I have to say, improved a lot recently, if you ask CQC, are you a regulator, or are you an inspector, or are you an improvement organisation, you'll get possibly 3 different answers, or the same answer, or the claim that they're all 3. And yet those 3 functions are quite different functions, and how we would set about improving an organisation is very different from how we'd set about inspecting one, is very different from setting a regulatory framework and checking whether an organisation is operating within it. So it's not their fault. They've been given by the politicians an entirely mixed set of tasks to do, which may be combinable but may not. So all new governments, of course, arrive being against regulation. They all announce at the beginning of their period in office that they are going to cut the red tape. And the public generally say, hurrah, that's a jolly good thing. The Daily Mail certainly says, hurrah, that's a jolly good thing, and especially we don't want any press regulation. And all governments depart having created a great deal more regulation. And we just heard David Cameron this week announcing out of the blue, as he likes to do, that he's going to criminalise teachers and health workers for not reporting female genital mutilation. I mean, how absurd an approach to a highly complex cultural issue in which the very group of people who are most likely to be able to help children are going to be criminalised. I mean, this is just the sort of madness of political approaches to regulation. And our present health ministers, and I have to say the very distinguished lawyer who advises them, have deeply confused the difference between legal, i.e. criminal sanctions, and regulatory, which are professional sanctions and are by no means criminal, and very specifically in regulation do not have the intention to punish, but to allow people space to rehabilitate and improve. Robert Francis said, we must end the blame culture in the NHS. And then he proceeded to announce a whole new set of crimes and punishments for people who work in the now blame-free NHS. I mean, it's incoherent to me. So regulation is a very, very blunt tool, and in my view is massively overused, and I'll come to that in a moment. And then we've got the word compassion. Now, compassion has recently, I think, acquired a new sort of political currency. Going back to 2012, Jane Cummings, the Chief Nursing Officer, said, is that me crackling? Said, nurses who fail to demonstrate compassionate care are betraying the values of their profession. And she talks about demonstrating compassionate care, and we'll come really, that's partly a point that Jocelyn touched on, is the difference between what you might call desirable behaviours and the emotional reason that they come about. In the same year, Keith Pearson, who's the chair of Health Education England, told the RCN Congress, nurses must have compassionate values. Selection standards need to be improved. Telling an entire audience of nurses selected under the inadequate standards, presumably that they lacked the compassion and skill to do their jobs. And then just recently, that paragon of compassion himself, Jeremy Hunt, announced that nurses will be trained to be more compassionate, and added something of a non sequitur, I think, that older people will be recruited to be nurses because their life experience makes them more compassionate. Well, I have to tell you, as an older person myself, my life experience has increasingly made me less compassionate. I am more grumpy, increasingly intolerant, and particularly so of politicians brandishing specious arguments. So is it conceivable that we can train people to be compassionate, that we can measure compassion, that we can regulate for compassion? I don't think so. Compassion is the feeling of empathy for the suffering of others. Quite simply, suffering together with another. But what we want in healthcare is not merely a doctor or a nurse who says, I feel your pain. We want someone who's going to do something about it. So it is the outcome of compassion that we need, not the emotion of compassion. And it is the behaviours that arise from compassion that are the proper outcomes of training, supervision, and regulation. And I want to say, Donna gave us just such a good example of that being done in the right way, with the quiet challenge to the nurse who wasn't behaving compassionately and who couldn't see that she wasn't, and who was challenged and trained and supported to be different. And that's what we need. And in a sense, we don't necessarily, if we get the right outcomes, need to make a judgment about the individual's emotional ability to empathise or to feel compassion. So regulation is a very, very blunt instrument for this purpose. And in the Principles of Right Touch Regulation, which we wrote in 2010, it has 8 simple principles. They're all in plain English. And one of them is use regulation only when it's necessary. And another is use the tools that are available to you already. And a third is get as near to the problem as possible. Because what went wrong with the nurse who was pushing the elderly lady on the trolley can only be dealt with by Donna and that nurse's colleagues and those people who see that incident. The regulator is somewhere else. The regulator is never in the room when something goes wrong. So the idea that you can solve the problems of the NHS through more and more and more layers of regulation is a complete delusion. And we only get it because for a politician, it's a much easier thing to say, I'm going to regulate this, than to actually deal with the problem. So laws and regulations generalize, but problems and failures are always particular. Now, in New Zealand, a few years ago, they actually had a public campaign to make compassion a legal requirement on health professionals. And they wanted to have it written into the Code of Consumer Rights. In the New Zealand framework, they have what's called the Health and Disability Services Consumer Rights. And the campaign was to have compassion written in as a consumer right. You've got a right to compassionate care. And the then Health and Disability Commissioner, who's called Professor Ron Patterson, who Jocelyn may know, a very wise and interesting lawyer, who's now actually the New Zealand Ombudsman. Ron Patterson wrote, he resisted this quite strongly as Commissioner, and even though he's a lawyer, not a doctor, and he wrote a really good article about it. And he noted in that something that actually Jocelyn's just touched on, which is the religious tradition of the concept of compassion. And he noted also some differences between traditions in whether they viewed compassion as a duty, as a moral duty, or compassion as a voluntary act, a gift to others. And Ron took the view, and I take the view as well, and I think from what Jocelyn says she does too, that compassion, in order to be real, has to be a gift. Compassion that is compelled is really not compassion at all. And he gives this little example. He says, and I think he was talking about his own experience, I may be deeply touched by the small kindness of a doctor gently touching my arm before a painful procedure. But how would I feel if I knew that he was merely following Protocol 3.2a and that it required him to carry out this act? A compassionate act compelled is not felt as a compassionate act by the recipient of the compassion. And Ron Patterson concluded that legislation was not the right solution to a lack of compassionate care. Of course, in rejecting the idea that we can't regulate for compassion, I'm not denying that there are frequent failures in the quality of care experienced by many patients and their families. But I want to know what the problem is before I prescribe the solution. In fact, the first principle of right touch regulation is describe the problem before you describe the solution. Politicians usually do it the other way around. Here is a solution looking for a problem. So let's ask ourselves if there is a compassion deficit, and we know there is in places, why and how does this occur? Because it's clearly not always and not everywhere. And we can go into hospitals or into healthcare facilities and we can see superb care in one ward or one outpatient clinic or one department, and the next door in the same hospital there is terrible care taking place. So we know that this is not always and not everywhere. So what are the circumstances in which healthcare professionals fail? In a paper that I wrote with my colleague Douglas Bilton last year, we argued that instilling compassion where it is lacking is unlikely to be successful. That is to say, by telling people the rules of compassion and ordering them to be compassionate is unlikely to be successful. And that regulators instead should concern themselves only with the outward results of compassion and not with people's inner motivations. In a work setting, conduct and behaviour can be measured, evaluated and assessed. Feelings and motivations cannot. Another weakness of the traditional model of professional regulation is that they see health professionals as individuals. Indeed, autonomy was for many years one of the identifiers of being a professional. One of the reasons, I think, and I agree with Jocelyn about this, one of the reasons that doctors think they're victims now is that they've lost an element of their autonomy. They only have to share it, of course, with other doctors, but it's still not just, they're still not quite free to make those decisions that they thought they could in the past. But regulating health professionals is still very focused on the individual's behaviour, and it's very hard for regulators to talk about regulating for teams, about understanding the context in which people operate, about saying this is a dysfunctional team, not a dysfunctional person. Regulators are still stuck on the individual standards and on the behaviour of the individual. And we know that the working environment has a huge impact on people's behaviour. The team you're in, the local leadership, and that can be right down at ward level, and it can be on shift level. It can change from shift to shift because of who's in charge. I'm particularly interested in the way in which people model behaviours. So the way in which people behave. I've got a bit of a joke I've been going around my office recently about, types of leadership, because I shouldn't say this. You're recording this, aren't you? But we sublet part of our office to the NHS Leadership Academy. One of the things they don't do is ever clear up a room after themselves. So I'm always going around cleaning the whiteboards of the jargon that's written on it by the leadership people. And my point was, if you see a piece of paper on the floor in the office, here's some types of leadership. See a piece of paper, pick it up, put it in the bin. One type of leadership. See a piece of paper, tell another person to pick it up and put it in the bin. See a piece of paper, tell the office manager to sort out the cleaning contract because it's not working properly. See a piece of paper, ignore it. Those are just 4 ways you can deal with responsibility for the environment in which you operate. And I think that the modelling of behaviour in a group is one of the single most important influences on how people respond. And we spend a lot of time in my organisation getting our new staff as they come in to understand the values that we're trying to live in the way we work, and saying to each other quite regularly, you know, if we're going to hold a mirror up to the regulators and say you're not doing very well, we better be good. And we're not always, of course, but you know, we have that in our minds. So, so bad practice breeds bad practice, and good fosters good. And as we know from the literature around whistleblowing, there are very few individuals who can stand up to a toxic culture, and those who do may have multiple motivations for their challenge to the status quo. And that brings me to resilience. Last year, I was at the European Health Policy Forum in Gashtin, and it was on the theme of resilience of health systems. Which healthcare services were surviving the economic downturn most effectively? And not surprisingly, it was turned out to be those that had strong financial controls and management of their budgets, good leadership, and lots of good management information and data. Now, I rather tentatively suggested to this august gathering that maybe if you wanted to run a resilient health system, you might need some resilient people to work in it. And this seemed to come across as a bit of a novel idea to the Eurocrats from WHO and the Commission. And it seems to me that in the difficult environments that lots of people work in, whether those are merely stressful environments or whether they're overly malfunctioning environments, without resilience there actually can't be any compassion. Because compassion, certainly enduring compassionate behaviour, as opposed from sentimental empathy, requires strength of character and strength of purpose. It can be very, very painful being genuinely compassionate towards someone who's genuinely ill. It can be even more difficult being compassionate, enduringly compassionate to someone who's ill and very difficult to deal with. And it's important to remember there are many people receiving healthcare who are difficult to deal with, sometimes because of their illness, sometimes, let's face it, because of personality. You know, when I was chief executive of the Alzheimer's Society, we used to have lunchtime ethical debates, which the staff would pick topics. And I remember my helpline manager once picking the topic, just because someone's got dementia doesn't mean they're not a horrid person. Discuss. So I think resilience is incredibly important, but it's not always a good in itself. And this is something to be interesting for your centre to think about. In our strategic review of the Nursing and Midwifery Council in 2010, a time when they were really failing badly as an organisation, and we went in really to try and look at all the things that were wrong and develop a plan to put it right. We described the staff culture that we observed as one of resigned resilience. And by that we meant that the staff knew they were failing, but they persevered nonetheless. They didn't give up with failing. Their defence against failing was to persevere, and actually that was standing in the way of their ability to improve, because they were really kind of stuck in a survival mood of resilience rather than an improvement mode of resilience. So resilience needs to do a great deal more than just help us to endure the difficult, although sometimes that is valuable enough. Resilience needs to underpin the moral virtues, not only so that good people can do good things in bad places, but so that good people can make bad places better. So let me conclude by putting these thoughts about links between compassion, resilience and regulation into different words. And it's interesting that I've chosen, totally independently of Jocelyn, one of her words, kindness. So what we need, I think, is kindness in the face of another's suffering, strength in the face of our own weaknesses, and self-discipline in the exercise of what is right. Kindness, courage, self-discipline. If we have those, as people, we may be able to provide compassionate care. Thank you.
My dad used to say to me, Donna, without stress, there's no life. So, you know, in order for life to keep on, you need a level of stress to get up out of it. So I just thought we would listen to you, because I think you've taken two sides of a coin, really, although you've agreed there's a lot of common ground there. Is there any challenge from either of you before I go to general questions?
Well, I'm not sure it's so much a challenge as possibly an expansion of what Jocelyn said. But I suppose your aspirations at the end for what those medical leaders were going to do seemed pretty detached from your description of what those medical leaders are currently like.
Yes.
And so the prospects of them doing it seem fairly remote to me. Well, and I'm particularly struck by your point about doctors seeing themselves as victims, because when I was working in the voluntary sector and working with people with disabilities, one of the big campaigns was to get rid of the word victim. People with disabilities hated being described as victims, and they all rejected the label victim, and they wanted to be people with disabilities, and they didn't want to be people suffering from, and all that language. And it's really interesting to see the language of victimhood being adopted by the most powerful as a tool, I suppose, since we can assume they do nothing without intent. So I'm just interested in that.
I suppose the question of medical leadership is one that really does concern me a lot, because I think it's, when I started the point of care, I was really keen to find advisors who were interested from the professions, who were interested in patients' experience. And it wasn't difficult to think about nurses, or to find nurses who were writing and standing up for, you know, compassionate care or patients' experience. It was incredibly hard to think of any known doctor nationally who had said, you know, this is something that I feel is very important for us to think about as a profession. When you looked at the response to Francis, when the Francis report was published, I'm not aware of any medical voice that came forward saying, these are problems that we should own ourselves as well. We need to think about this. There are individual doctors, and I was fortunate to be advised by a dear friend called Kieran Sweeney. You might have read some of his work. So there are doctors who are known as kind of beacons of light, as it were. But leadership of the profession in this area is thin on the ground. So one of my ambitions is that there will be a cohort of doctors over time who are known to be passionately interested in this, in the way that there have been over the last 10 years doctors coming forward who we can all think about probably, and we know that they're fundamentally interested in patient safety. 15 years ago, there was no talk of harm to patients, there was no recognition of it, and after a movement to, you know, become aware, to find the research, to do the research, to develop the tools to provide the training. There is a cadre of doctors who you could say absolutely get it, and I would like to see the same for patients' experience, and I think that many of the doctors we've worked with, who are mostly young consultants rather than the older ones, I think they will be the leaders for this sort of stuff. But also, I just think that doctors are very responsive to public opinion, and I think that, I'm convinced that there is a groundswell of discussion going on around patients' experience now that there wasn't there when I started the point of care, and that we'll begin to see leadership of the medical profession. I'm always an optimist, Harry. Who are saying this and thinking about it and thinking about what it means for professional education.
The optimist is a pessimist who's not in touch with reality.
So I'm quite struck by that, because any of you that know me will know that I think I see patient care as teamwork. And I guess in the 30 years that I've been in the health service, at an individual level, I've seen doctors devastated about patient safety, about patient experience, about patient harm. And so, but equally, in terms of that teamwork, so, as a ward sister, it was my job to have a junior doctor understand patient experience if he missed it. Do you know what I'm saying? It's not, I don't think, first of all, I don't think doctors' training was ever about that. And therefore, I think we are now introducing that into a level of training. So I don't think they were absent from patient experience, patient harm, but it was so much on an individual basis. And so I'm not surprised that we didn't have massive research into that in the way that we had research into, cellular, molecular, all of those other things that scientists do. But I do think that there's an important structure in the health service that says a patient and they're facilitating them to good health is not the result of one person. It is a team of people that surround that person. And just going back, while I remember, because this is something I do want to make, is I do think that the team of people, in exactly the same way that the health service is built in relation to Frances, it wasn't just the director of nursing that refused to accept her responsibility all the way up the NHS. The chief nurse of England wasn't responsible for patient care. Well, from my perspective, it's a team approach. So whether you're in the policy bit or the hands-on bit, we're all responsible. And so for me, I just would put that out there, that I don't think it's just the doctor, the leadership of medicine. I think it is the team approach, and that surrounds a patient is a team. That works in a hospital, whether is a team. That works on a ward is a team. So I think it's just a debate that we sometimes want to rest everything on one professional's head. And actually one professional can't do everything. They may be the person that seeks the operation or slices the skin, but there are other people that will, contribute to experience.
No, I'm very aware of that, Donna, but what I see is that doctors have a greater influence over teamwork than their colleagues, so that how they behave determines the culture of the team. You can have a really great team without the doctor if the doctor's not interested, but actually medical leadership is better. But I was very interested in Harry's point about individuals and team and regulation, because I think it's directly relevant to what we're talking about.
I think that internationally regulators are all struggling with the fact that they have models of regulation that don't fit the description of how care is provided that Donna's just given us, and they don't. And of course, professional regulation is about tribes. I mean, it grew out of the sort of guild model, and the thing was you got a statutory monopoly by promising to self-regulate. And then you could control the market you were in. The work we're doing in Hong Kong is because the Hong Kong government is deeply concerned at the fact that their medical regulator is only interested in keeping up the price of doctors in Hong Kong by restricting the supply. So they've set such incredibly difficult entry standards so that, for instance, if you're a young Chinese person and you come to Cambridge and get a first-class honours in medicine, you can't go back and practice in Hong Kong until you've gone through a Chinese university course in Chinese, even if Chinese is in any event your language, because the Hong Kong Medical Association says you can't. And that has limited the supply of doctors in Hong Kong. And we see that it's worse in other countries. In Europe, at least, we have free movement of labour, which has actually opened up our system to healthcare professionals from all kinds of countries and cultures and backgrounds who are actually helping to reflect the population as a whole, who are from all kinds of cultures and backgrounds. But in many other countries, it's so regulation is a barrier to progress and change. And some of the most innovative healthcare that you see around the world is in countries that have no regulation, because there's nothing to stop them from thinking quite differently.
Like
India would be a good example, and Mexico.
I'm Jenny Nathan. Is this working? Sarah, can you hear? Can you hear that? And it's going to be a hodgepodge of various points. But one thing which I particularly direct in response to Jocelyn's presentation is that by the virtue of my training, I am made, or I have to become somewhat invulnerable. I have to put aside my vulnerability. I have to be able to work. When I was training, 48 hours on the trot, or 50 whatever hours on the trot, I had to be able to delay having meals. I had to be able to delay going to the loo. I had to put all of that aside. Even now, as a trained, qualified GP who's not going through the rigmarole of the actual on-call system, I have to cope with 45 people a day. There's huge amounts of uncertainty. To be in contact with my vulnerability in that situation, I'm not sure that I'd cope. I'm simply not sure that I'd cope. And so I've got and these are ongoing questions for myself. How can I actually be an empathic practitioner and be human? How do I do it in a system that demands so much of me? So that's one point. I really don't know the answer to that. I really don't know the answer to it. I mean, I found some sort of slightly personal answers which are balancing the clinical with other things, which help me think about it a bit more, which is brilliant, and lucky me. But I think there's a huge issue. I've spoken to colleagues in other parts of London who don't get to go to the loo until 4 in the afternoon. It's pretty desperate. And so if you can't even go to the loo, as someone said, detox, how on earth can you take more stuff on? How on earth can you do that? How on earth can you be present to somebody else when you've got pressing full body? Really, really basic things. The other thing which I agree with Harry, but I think it's really, really important, this concept of a resilient organisation. And I sort of wonder how that fits in with the words containment and holding. Those are words that I've come across more from a sort of slightly psychoanalytic background. What does that mean? And one of the things it means for me is very much not just the teamwork around the patient, but actually the teamwork responding to one another as human beings. And I think that's the thing. I think there is a victimhood, and I think the victimhood is on the level of our humanity. That we actually we go to work, we process huge amounts of stuff, and where's the human in this? Where's my personhood? I think that's a very difficult thing.
Thank you. Does anybody want to respond to
Why don't we take some more
comments
and then...
Oh, okay. That's the challenge then, isn't it? Let's do it.
Hi, thank you. My name's Jenny William from Trinity College in Havering. I'm a barrister, also doing psychology as a PhD. I did a paper recently on research into barristers and vicarious trauma, barristers practicing criminal law, and I'm very struck by what Jocelyn was talking about, the ego of the profession of the medic, and I think there's a lot of mirroring in that ego perhaps of barristers, and I am one myself in this case, so I can
say that. And one of the things that I found about vicarious trauma, obviously empathic engagement is one of the means by which professionals can get vicarious trauma. And so I asked the barristers about empathy, and it came as a surprise to many people that I asked about empathy in the context of the law at all. But one of the things that the barristers described very much was, and the way I took it in analysing it, was the difference between a cognitive empathy in understanding the plight of somebody else and affective empathy, because actually they use the word stepping into the shoes. And the barrister even used the words that there's an emotional Rubicon that you don't step beyond, and if you do step beyond that, you cease to be of use and benefit to your client. And I was very struck by that in the way of that element of self-care. And I suppose I'm interested, Jocelyn, your views on that concept of empathy, in that I very much understand the necessity for empathy for the patient, but also then I think what you say, the effects that empathy can have on the well-being of the other practitioners. I'm interested in your views on that.
Okay, we'll take one more question. So a question about the term patient experience and what that is, how we know what that is. I've been to quite a few lectures and seminars where that's been talked about, and you have statistics saying patients say this, patients want this, and you have 64% or something. But if you change the word patient to people, the whole statistic would be meaningless. Because you have a very wide range of views, very wide range of experiences. And what happens when you make, so the question is, what happens when you make this thing called the patient experience the centre of healthcare? One of the problems that are raised. I've also done a few observations of medical education. I think that there's a bit of a tendency for the patient to become a bit of an abstract entity in order to turn it something you can learn from, or turn it something that has an experience that can become the subject of education. And one of the characteristics of this abstraction is that it does tend to become a victim, which I think links back to some of the discussion we were talking about victims. And it raises really interesting questions about, for me, about what is this thing called the patient. I speak as a non-clinician. Within medicine, how does it become an object that you can kind of learn from or speak to? What are the dangers or risks of levelling out differences between patients? Okay, is there a mic down
there is.
David, that we could
There you
just
are.
come to those three?
I'm just giving Jocelyn the mic so she can answer the questions.
Well, I'll answer the ones that I think would address directly to me. I hear what you're saying, Jenny, and I know it's true as well. I think that, I know first that something about the way that medical doctors are trained, and I think invulnerability is part of it, as you say. And I think the question of how to retain your humanity as a practitioner is what really brought me into doing the point of care. I think there are some practices that help. I think Berlin groups in general practice. I think Schwartz rounds that we promote. I went to one today, for example, at King's College Hospital, which was really where the discussion was about a patient who was dying and his son, and the son was completely uncontained and took up hours of the staff's time. The palliative care team were presenting the case, and you could hear their anger, their frustration, how overwhelmed they were, and this man happened to come from Kosovo, and the discussion opened up, and the discussion was all about boundaries between yourself as a person, yourself as a professional, the cultural issues. Did it make, it was like Harry saying about, some people with dementia are just nasty, was this man just nasty, and so on. And it seemed, and the purpose of those meetings is to allow people to reconnect to themselves and to each other. And that's it. And I think that makes an incredible difference. What I was talking about really was the the denial of that as a problem, and that's what I would like to see much more talked about, much more openly reflected upon. And in response to what the barrister from Ireland was saying, I think that I agree. I think there is a difference between cognitive and affective, and actually more and more I think it's the cognitive that matters. And that sometimes when I'm talking about our work, the response from clinicians is, you cannot expect all of us to feel the pain of, but actually when you look at what patients are asking for, it's much more to do with what Javi Carrel calls the low-grade insults. It's the stuff to do with people ignoring you when you say, actually my name's Jocelyn, not Susanna. It may say Susanna on my forms, but I'm Jocelyn. It's actually really, it's things to do with just listening to people respectfully and acting on what they say. It's not a requirement, I don't see. I completely agree with Harry these days, that it's about the way that, it's about agreeing that what we're trying to do here is offer a service that is kind and respectful and polite and listens. And how we feel we may have had the worst day in the world, but actually we know how to do that, and we talk about it, and in the team we agree that this is how we're going to work. That's what I think is where we need to be heading.
No, and I mean, I would just say that in a sense it's partly the points both of you are making were what I was groping around when I talked about, I don't just want, doctor, I feel your pain. I want, doctor, you're going to do something about it. And I want the behaviours, and I don't need the emotional content. But I think the point that you're making, and it's one that young medical students talk to me about, is that difficulty once they've got over what for many of them is the excitement of qualifying and becoming a doctor, and the sort of rush of achievement and even power, is suddenly, as one said to me, ordering the drugs in the hospital isn't at all like it was when we were being trained. They don't arrive. I have to go down and argue with the pharmacy to get the medicines I want for them. They start to get all those stresses that you're talking about that require them to have a level of, and this is where the resilience thing comes in, a level of personal resilience that is not just about the people that they're looking after, but about looking after themselves. And that was my point at the end about you need the strength to look after yourself in order to have the competence to look after others. And that's a really hard balance for people to get, I think. It's a lot that we ask of people to do that.
Yeah.
I just wanted to make a comment actually, because I trained as a barrister halfway through after I became a nurse. And I have to say that two fundamental principles that I took away from that was the right for self-determination and respect for persons. And I think that just training as a lawyer shaped my career as a nurse. So I did my pupillage and then ran back as quickly as I could, because it was no different running down to a police cell and having that conversation than having that same conversation with a sick patient on ward. So just as someone that experienced both sides of that chasm, I think that just you do, there is something that there is a self-preservation that you can't step beyond. But that doesn't stop the empathy, the cognitive empathy that you would have for somebody, whether they were in a cell or were in a hospital bed. And that is more to do with respecting them as people and their right to self-determine. It's not necessarily understanding every aspect of the things that they may have done wrong, or the fact that, and there is this ability that you have to suspend judgment. And so actually in the same way that as a nurse, I recognise that you may be smoking and it's not good for you, that doesn't prohibit me treating you. And there is something that goes, I think, along that paradigm. So it's just an interesting observation, but I promised to come up to you, and I'll come back to you.
Thank you very much. I'm Andy Bradley from Frameworks for Change. A couple of points. I think we need to contemplate more deeply on the question, how could they not see? And I think there are two stories about that. One was how could they not see the piece of paper? So I think there's a fifth leadership paradigm, which is they don't even see the piece of paper. The question, how could they not see, is a question of humanity and relentlessness, I think, as well as the medical model.
I agree.
There's actually really good evidence that compassion can be trained and cultivated. And I think it's important just to put that into the mix. That's coming through very strongly globally. Some of us are lucky enough to be trained in compassion through the way we're raised, parents who are living through adversity. Many of us do not have that training, and there's good evidence that it can be trained. And my final point, coming to my question really, which is the development of empathy in responding to patients the easy bit? How can we extend ourselves to develop a deeper empathy and compassion for those many medics who look away? Because it's that makes it harder to practice medicine in an unconnected way, as the rewards of caring deeply as well as competently do not flow.
Wow. You got that. Is there any... Did you want to say something?
Can I was being deliberately polemical tonight, but I think that I think what you're talking about, Andy, in sort of how could they not see, is that the power of institutionalisation, which is incredibly strong, I think, in every walk of life. You know, Harry probably does see things in his office, but I bet a lot of his colleagues don't, because they're just inured to their environment. They see.
Certainly not.
Do you know what I mean? I think, you know, the habit, as you say, and that's why team is so important, I think, and why things like shadowing patients are so important. It's why these practices that help you to see deliberate, intentional practices are so important, because even if you were to change the culture, it would inevitably be the case that as Kieran said, you know, you're basically doing the same rather dull stuff to different people most of the time, and staying alive to their individuality is an immense challenge for everybody. So yes, I think it's a really important dimension.
I just want to defend my colleagues against that calumny. They're so enthusiastic about picking up pieces of paper from the floor. We bump into each other as we rush for them. They're just not quite as keen on cleaning the whiteboard.
William House. I was a GP for 30 years, and I'm chair of the British Holistic Medical Association, and I also run a community development programme now in a small town. First of all, power. Bertrand Russell said, from any particular perspective, power, the locus of power is always somewhere else. And certainly, I know doctors are powerful, but I don't remember, in my mature years at any rate, when I was young I did, I was kind of rather taken by the power that I was suddenly given and thought I deserved. But it became clear relatively soon that actually we weren't really that powerful. An interesting thing I've noticed since giving up practicing clinical medicine and working in the same community in which I was looking after, but in the role of community development, I'm still the same person with the same knowledge and presumably an ex-pillar of the community. But people in the community are perfectly happy to ignore me. And if they don't like what I say, they don't take any notice. I'm not given any special privileges. So it was actually the role that I occupied that they wanted that, not the person.
Yeah.
There's so many things have come up. I think you don't hear much from doctors, rank and file doctors, probably because actually being a rank and file doctor is really, really busy. And getting your voice heard, writing a good article is seriously time consuming. And it also requires creative space in your head. And it's, you know, you have to go and find them and interview them, it's hard. Regulation, my sense is, not as an expert in regulation, but the way I see it, it's a bit like wildlife garden. I have a wildlife garden. And I know that if I want that garden to thrive, what I need to do is get the soil right. To get the right mix of habitats. And the only regulation I do is to pull out the things that would take over completely if I let them. But apart from that, actually, my role is nurturing the environment. And so the regulator's job as I see it, is to pull the weeds out. Okay. And resilience and empathy and compassion.
Pass that on to the GMC.
Resilience, empathy and compassion. For me, the key thing is to be curious about people. After all these years, that's what I come to. In the end, I was aware of being fascinated by people. And if you can cultivate that in yourself, then every person that walks in through the door is a joy. Even if they're really rude and difficult. It's always possible to be fascinated by something, the socks they've got, or the earrings that don't match. There's always something. Then you're in a different plane, and then you can feel for that person, that unique individual in front of you. And I think that helps resilience too. I could go on, but I've said it.
I want some of what you're on, definitely. If I could alter the paragraph.
Sorry, I want to see something. I think I'd have to confess that because I'm an arts therapist, and we were a very small group who pushed for our own statutory regulations back in 1997 after 10 years of art graft, and so proposed who are these people making all this noise, and it turned out it was music therapists. So we and we'll manage that. And I guess that links to my sort of 15 years of practice, and wondering, as a regulated health professional, one of 300 in the NHS, can you imagine how hard that is, my GP colleague? On reflection, I picked up my sense of a little bit of irritation at you describing how hard your job is, and I guess that's what's around in the room for all of us, you know, which is how we can manage the power differential. But my question is, I wonder where the arts and creativity are in all of this, and I say that to out you a little bit more, Harry, as the person who waved the flags for the arts in 2007. You now need to look deeper in the recesses of the Department of Health or NHS England archives for that report, but it's spoke very clearly to the hope the arts might have to help people keep going and find that aliveness.
Yeah, well, that could get me onto another theme for another week, couldn't it? I mean, I still do a lot of work in arts and health, and I was speaking at a wonderful conference about 2 weeks ago on reminiscence therapy for people with cognitive impairment, and particularly about the use of the arts in rekindling creativity. And I'll give a plug for my charity that I'm patron of, called Arts for Dementia, which is a fantastic small charity, really trying to help people who are losing their cognitive skills to reconnect and to use their own artistic appreciation for communication and memory and quality of life. So I mean, I think where this touches on Jocelyn's work in particular is the sense in which the arts improve people's quality of life, which is part of that whole issue of what our experience is. I think one has to be a little bit careful, because it too quickly turns into paintings in hospitals. And I quite like paintings in hospitals. I like paintings in my own home, but that's not what we're really talking about, is it? We're talking about something that taps much more deeply into what we are as people. And I was at the proms the night before last, and I always come away from those concerts sort of feeling, I feel better when I wake up the next day. And I think, why do I feel better this morning? And then I think, well, it was that wonderful Mahler I heard last night, or Brahms I heard last night. It kind of lives with you. So, but I'm just riffing on about art, so all I'm going to say is they're still very important to me. The report that was mentioned is a report called Arts and Health, which I wrote and chaired the group that wrote for the Arts Council and the Department of Health. And it's interesting, the history of that was that just before we were about to publish it, the Secretary of State, who was at the time Andy Burnham, there was this whole fuss in the press about that big rock that was put outside University College Hospital. What a waste of public money, you know, putting this lump of art outside the hospital, absolute disgrace. And Andy Burnham had written the preface to the, well, he hadn't written it, I'd written it, and he'd signed the preface to the report, and his office said, you can't publish it, because the Secretary of State can't possibly be associated with this paean of praise to arts activities in the health service because of this rock. And they withdrew his forward. And they told us that we couldn't publish the report, but actually we said it had already been printed and distributed. Which, of course, is entirely true. I wouldn't do anything that wasn't.
Is it I mean, I think what you know, the art therapy world and is part of the soil, isn't it? That this man was talking about. It's kind of. I mean, what I this is why I like the idea of designing environments of care, that so designing the social relations as well as the physical environment, and that's what I think is really what needs to be thought through, and much more than we've done so far, I think. And so what we were talking about last week is part of what needs to be designed in and dealt with, which is all the stress and burnout and lack of teamness. And what I'm trying to talk about is some aspects of medical culture that I think are detrimental. But I think that, you know, it's so important to think about the things that you need to bring into the environment as well to make it a healthier one for the people who work there and the people who are cared for.
I've got two more people, well, two up here and probably Dr. House again down there. So if we can just, and then we've got to conclude, I know, so it's not. So,
my name is Brendan Martin. I work with KPMG in our work with healthcare regulators, but I'm a pharmacist and practiced for 3 years, and part of the reason for moving out of that environment was the busyness that's been mentioned by some of the colleagues who've spoken before. Incredibly difficult to have an impact on the overall healthcare landscape when your day is continually filled with work where you don't necessarily get to eat, go to the toilet till 5:30 sometimes. So first point really is about leadership, and I think that what we're talking about, the arts and the input that has, represents the humanity that can be brought into healthcare. And all you have to do is look at a GP-led initiative in Cornwell recently. I
I think that humanity's out there, and I think that it can be fostered from nothing. And that's my opinion. I think that Jocelyn, definitely, I'll be on your side in it. Certainly. Second point is about a practical step, data. I know data sometimes can be demonized, but as a pharmacist, I find that sometimes data can elucidate things that people don't really consider. Sometimes you speak to GPs and they talk about prescribing trends. How many times do people look at whether the prescriptions that you give are actually redeemed? And what data is out there to tell us, does my grandpa who goes to the doctor actually take the prescription in the pharmacy to be redeemed? And how much of what doctors think they do actually gets done? So, and that's not a criticism of the profession, because I believe there's some amazing people in the profession, and I think that they should be fostered. The third point is about affective and cognitive empathy, and about how it can be taught. And I'd like to just direct it at Harry, really, ask if it can be taught, can it be regulated? It's a very, very difficult thing to pin down, and I'd just like some of your thoughts.
I think in answer to that, I'd just say, well, even if it could be regulated, is it desirable to regulate it? Because I'm very strongly against regulating everything that moves.
Well, the absence of it, so absolutely the presence of it should be encouraged, but what course?
I think there are many. I mean, we've had good examples of that. There are many ways in which we can encourage the good to happen, which don't involve regulating anything. And I think that my concern, in a way, and it goes to the lovely analogy of the wildlife garden, is my concern is that we turn the wildlife garden into one of those municipal parks where even the colour coordinated pelargoniums look dead, even though they're not. And I don't think that's the kind of world I want. And I think that going way back, one of the people who was on the Better Regulation Task Force many years ago said, regulation is like the drains. We should only notice when they smell. And I rather like that. I mean, I think regulation pretty much should be invisible. It's one of the reasons why I keep my organisation fairly quiet. We don't do what CQC did, which was, put press releases out every time we do a report saying somebody's messed up, because we like them to, sort it out and do better. We don't want to just create an environment in which we're shouting all the time publicly that people are no good. And our job, inevitably, we see the worst of healthcare. We see all the people whose practice has failed terribly. I saw 2 cases this morning. One of a clinical psychologist who had a highly abusive sexual relationship with a woman patient, and another of a nurse who was suspended for clinical failings and then applied for a job with another employer and worked for 9 months while suspended from the nursing register. So we see the bad end. So it inevitably makes me a bit jaded sometimes. Jocelyn? No?
I'm Helen Davis. I'm a patient rep in an acute trust, but also a former practitioner in end-of-life care, drugs and alcohol and so on. And very interested, part of my work is mental health in the workplace. Fabulous presentations. I've really appreciated the opportunity to hear your thoughts. And I thought it was really refreshing to hear some reflections on the vulnerability of clinicians, because I am so often struck by sitting in, as a patient rep, how all the clinicians and managers talk about patients as though they are other. And I think that it is a protective mechanism, that to allow yourself to consider that could be me is very frightening, but it could be any of us. And I was just thinking about the friends and family test. I think the concept behind that is probably really useful. That basic question of, would I be somehow it's become very over-bureaucratised. There's something on NHS England's website today about introducing a primary care. It's about a 15-page document. And it is also something that's asked of patients. I think it would be great if Schwartz rounds and fabulous if something light touch, right touch, getting it as close to the problem as possible, could be built into team meetings, which is a question around how, is this a good enough service for my mom, my brother, sister? How can we take it a step closer to being that? One of the NEDs, non-execs at the hospital I work with, said that that's how he prefers to frame the question, not what's wrong, but what will take us a step closer to where we would like the service to be, assuming that people are in it because they want it to be fabulous. And I also do think that supporting those frontline non-clinical staff to be compassionate, to have those conversations and be part of those conversations is going to be critical. And if we can move beyond yet another sort of survey to something that actually gets conversations going within those departments.
You can see I've been summoned, I'm a bad chair.
No, you'll be bad chair in about 2 minutes.
So,
Just tell a little story.
if it's less than 2 minutes, if your story is less than 2 minutes, you can tell it.
We're regulating that.
It's about a research project that I did in which we placed, with patients' permission and ethics and all the rest of it, a novelist in consultations with 8 GPs around Bath, where I live. And her brief was to write a vignette about every patient as if they were a character in their own story. So she did that, and there were 2 liners. And then there were 50, 55 patients, and we got the GPs together and shared some of those vignettes with them. They were utterly extraordinary, these little pieces of writing. The GPs didn't know which patients were theirs, and when they heard a vignette, one of them would say, I know who that is. And they were, it's difficult to describe their reaction. Their reaction was a kind of a delayed grief reaction, really, for something they realised that they weren't seeing. They weren't seeing the human being. It's like the piece of paper, You weren't seeing the piece of paper. The novelist saw it and wrote about it. And they were in tears, some of the GPs, in the focus group. It was a very odd focus group. I have written it up in the Journal of Holistic Healthcare, but it's a shadow of what it could have been, the writing, because I didn't really understand what I'd done, and I found it really, really difficult to write it up. It was such an extraordinary experience. Anyway, so I thought I'd tell you that little story. It's all there, it's all possible. It's about fascination and creativity. It's mixing the arts, becoming an artist. I consider myself to be an artist.
And a gardener.
Well, I think it's been another fascinating evening. I've really enjoyed it. Different stories, different speakers. So thank you both to Harry and Jocelyn. And I guess what I'd say is that we just need to remember that every day there are lots of people in the NHS that practice well. Harry hears the bad stories. I tell you about the mishap that I see. But every single day I can quote you people that have enough stress to deliver that purpose of trying to improve someone else's life. So I just wanted to thank you for participating in this debate with us. Thank you.
Well, they're great. Good. Thank you very much. And the comments and questions have been wonderful too. And we'll be collecting everything, doing a video and getting this webcast eventually. But it falls to me to do a couple of things. One is to say, come and have a drink with us in the pavilion and a few nuts afterwards. to thank Donna, to thank Jocelyn, to thank Harry again, and just to reflect on what William said about curiosity.
We're all in the garden. The fairies have arrived.
Yeah. So curiosity and something that William touched on, I think everyone's touched on here tonight, is how to bring the soul back into healthcare, and it has a lot to do with noticing our own ensoulment, I think, our own humanity, something that isn't working and crashing out at the end of the day. So we need to get a life. So thank you all very much. Next week, my goodness, next week we have our grand finale with Penny Campling, author of Intelligent Kindness, and Iona Heath, whom God preserve. So thank you very much. Good night.